Okay, hello everyone. I'm going to keep admitting people. I think people just are a little late today, but I'm Elena, and this is our April 2023 coaching call. I can't believe we're already in April. And we're going to start today with a presentation from Amber, and then we're going to move into our main presentation of the day by Dr. Gold, who'll be presenting on the updated toxicology guidance. So I will share my screen and pass it over to Amber.
Hi, friends, familiar and new. It's lovely to see you all again. One of our goals at CPCQC, particularly in our perinatal substance use program, is to really endeavor to center the voice of the patient. And so we actually have an active program within CPCQC on patient engagement and lived experience. And we're building up that program in order to be able to integrate that more into our work. But we also work closely with Tough as a Mother, which is an excellent organization that really seeks to bring light to perinatal substance use. And so I wanted to start today's call just to kind of center us in the work that we're doing by sharing a short video here of lived experience. Elena, I don't know if there's audio.
Is there no audio? Gosh darn it. Why does nothing ever work as I want it to? Okay, tell me if it works in now.
Hi, my name is Alicia Kroll. I am from Grand Junction, Colorado, and I am a mom in recovery. The moment I knew I needed help was probably when my mom passed away. It really was a series of unfortunate events. In October, my husband went to prison. In November, my 3-year-old son went to live with his biological father, of whom he had never met. And February is when my mom passed away. And I really just felt lost, like I had lost everything that was important to me in my life. And how could I possibly continue to live? So I gave myself 2 options. Either I kill myself or I reach out and ask for help. And so I got honest with myself and with my probation officer. And I told him I wanted to live. And I can't get clean on my own. I admitted that I had a serious addiction to meth and heroin. And instead of putting me in jail, he actually helped me. Of course, I continued to get into trouble and just couldn't stay out of it. So they ended up revoking my probation and they reinstated it under the condition that I go to a 3-month treatment program here in Grand Junction. And that was what I wanted. So I got what I wanted. I definitely wanted to get clean. I had been living in my addiction for 2 years and I had already lost so much. I couldn't imagine losing anything else. So I complied. I went to treatment. I got out and I came to an Oxford house. And today I get to see my son whenever I can make a trip out there. He lives in California, so it's kind of far away, but I also get to talk to him and FaceTime him every day or every other day. And I'm working towards getting some more physical custody. I do get various times of the year. I am starting to get a week. And so that's awesome. It's taken a long time to get to where I'm at. I have 17 months of sobriety today, and I'm very blessed and grateful to be alive. So the biggest change in my life since starting this journey has been the fulfillment that I get out of life today. I recently got hired on with Oxford House, which is really awesome. It's within the realm of recovery, which is a huge change for me. Everything that I do, I eat, sleep, and breathe recovery. I have a lot of support. I live in a house with 6 other women, and we all support each other. We're like one big family. And that really means a lot to me because I have lost a lot of my family due to addiction. And so living in a house full of recovering addicts has definitely changed my perspective on life today. I think what I most need to say is to my loved ones, my father mainly because he's the only person that I have left, and he's never once given up on me. He's never once stepped out of my life, and even when I was difficult, he was always there for me. So I want to say thank you, Dad. I appreciate you. I love you. As far as the community, never give up on somebody who is in active addiction or in recovery. People are changing rapidly, and all they need is healthy support and the will to get better. That's really all it takes to get into recovery. If you can reach out and ask for help, or if somebody notices the signs of somebody in active addiction, like reach out to that person. Don't let that person die, because you never know when somebody is going to die from an overdose or from suicide. Addiction takes a huge toll on a person, and all they need is somebody to tell them that it's going to be okay. My name is Alicia Kroll, and I am tough as a mother.
Thanks. So those are difficult words to hear. And I think us just continuing to come back to what Alicia shared, which is that the most powerful thing in her life was that people didn't give up on her. And so I think it's just a great place for us to continue to come back to whenever we're getting into the nuts and bolts or how we're actually addressing perinatal substance use, to kind of ground ourselves in the voice of the patient. So I'm going to do a pivot here from that lived experience, and we're going to take just a couple more minutes to dive back into our quality improvement journey. I know that we are all very much looking forward to our expert speaker today on a topic that we all have many questions about. But because we are a QI collaborative, I think it's really important that we continue our journey, making sure that our teams have the tools that they need to give the perinatal substance use care that is going to save lives. So just as a brief review from our first learning collaborative session, we really reviewed the facts that suicide and unintended drug overdose are the leading causes of maternal mortality in Colorado, and that 80% of those deaths are preventable, and our actions are truly what can save lives. I always share during my QI talks that the reason I love quality improvement is because it gives us just really direct action plans in order to address these really meaningful causes of maternal mortality. So Elena, you can go to the next slide. Last session, we spent some time not only reviewing the Institute of Healthcare Improvement's model of improvement that we use to structure our quality improvement projects, but together we talked about what aim statements are and how they might direct and center our work as a team. That is the first step in addressing quality improvement, is deciding what it is that we're trying to accomplish. And as a team, last week, we started to look at Jamboards, and we all contributed to a Jamboard that listed some of the aims that our teams have. You can go to the next slide, Elena. What I did is I took some of those aims that our team members gave us, and I revised them into kind of high quality aim statements here. And I wanted to go over a couple of those aim statements to give you an idea. Many of our facilities have the same aims and the same goals. And so I'm hoping that maybe one or two of these aim statements might jump out to you for your facility. One of our facilities said that their goal was to implement respectful maternity care for persons who are affected by substance use. That's an excellent goal. A kind of specific aim statement for that would be by the end of this year, that facility could host or facilitate a respectful maternity care training. And the goal for that would be a 75% attendance by all staff nurses. It's actionable, it's time limited, it's pretty specific, and it could center your team around a very specific goal in order to achieve that. One of the teams also highlighted that they wanted to have resources for initiating treatment for inpatient and outpatient referrals. We sort of switched that into a specific aim statement by saying by June 2023, that champion will attend, the champion team from that facility will attend at least one meeting with CPCQC's Moms Plus program. That program discusses provider training for MOUD initiation. And then finally, one of our other teams identified that they wanted easily accessible community resources to provide to patients at discharge. To make that actionable, we said by June 2023, that team could develop something like a Google document or a Word document that contains the community resources. And this can be pretty comprehensive: social, behavioral, mental health, substance use, obstetric, lactation resources, anything that's available in their setting. And then this could possibly be made into an epic dot phrase, or it could be printed for the patients at discharge. So again, an actionable step that their team would be able to take. Let's go to the next slide. Elena. So once your team decides on what is our specific aim, when we're talking about improving care for perinatal substance use, what is it that we're focusing on? Once you've decided on that focus, the next goal for your team is to decide what are your change ideas? What are the things that are actually going to address that focus? My 2 pieces of advice for change ideas are don't just guess at change ideas and don't brainstorm alone. So I'm going to tell you pretty quickly here just 2 really valuable tools that can help you come up with change ideas that are relevant to your setting and your patient population. Next slide. The first tool, many of you may have heard of this tool because when I gave you your QI feedback for your data dashboards, I included this tool, and it's called the 5 Whys tool. And it's one of the most simple quality improvement tools you can use. It's simply saying that when a problem occurs or when you're trying to address an aim, you drill down by asking why 5 times. So I'm going to go through a quick exercise with you on what this might look like for you. Next slide. So starting on the left-hand side here, the aim for this facility or the problem that they were trying to address was that 50% of the patients who screened positive for substance use were not scheduling a postpartum visit prior to discharge. So the team started by saying why. The team then kind of came up with a few different reasons. Ideally, they were getting provider feedback, nurse feedback, management feedback. Those reasons said staff didn't know the protocol. Maybe there was nowhere to document the postpartum visit was scheduled. The staff didn't have time to schedule that visit, or the patients maybe declined to schedule. If you continue on and ask why for each of those, then you're going to get different answers, right? Well, if the staff don't know the protocol, why is that? It's because there's no unit-wide education on that topic. If there's nowhere to document it, why is it? And the problem there was it was not part of the discharge checklist. So as you can see here, this is a very linear process. And your team, in the end, and the goal again is to ask why 4 to 5 times, and then you're going to land on a very actionable, very specific step that you can address in order to bring it back to the problem that we see. And next slide. Actually, Elena, going back to the whys, like you don't need a template for this. I obviously just created this on a slide. A whiteboard would be valuable. A Jamboard could be really valuable. This is something that you could literally just verbalize with your team. And so I like it because it's a low resource quality improvement tool. Next slide. The other one I wanted to bring up is what's called a cause and effect, or a fishbone diagram. It has similar characteristics to the 5 Why tool, but it's a much more visual tool, and it's used to logically organize the possible causes for a specific problem. I'm not going to walk you through this tool. This one does benefit from having some sort of paper or drawn out tool for you to work from when your team is using this. But I want you to kind of imagine on the right-hand side here, I've listed a common problem for our facilities, and that's the obstetric and the behavioral healthcare providers aren't necessarily communicating effectively for patient care. So if you can imagine that problem, you put that problem here on the right side of your cause and effect or fishbone diagram. And then let's go through the leading indicators or the leading causes for that problem. You would think about what in the environment in your setting is contributing to that. Who are the people who are the key players that are contributing to that problem? How are you actually able to measure that there's not good communication? What outcomes are you looking at? And so not all of the sort of fishbone edges here are going to apply to every problem, but it at least gives you a starting point to look pretty holistically at a problem to say what's the most meaningful way that we can address that problem first step. Next slide. So I want to challenge you this month. You have an entire month here for homework. I want you to use your aim statement, either one that you developed with us last month, and I'm going to reshare the Jamboard that we used in case if you put an aim statement on that Jamboard, I helped kind of give some feedback on your aim statement if you want to continue to use it, or brainstorm a new aim statement if that's what your facility would benefit from. And then I want you to use one of these 2 tools to brainstorm some change ideas. I really want you to not just do this yourself. If there's a possibility to involve 1, 2, 3 other team members to get outside input, that's the most valuable way to come up with change ideas. You are welcome to schedule a one-on-one with Elena and I if you want to kind of go through this process with us at least once before you bring it to your teams. We'd be happy to do that for you. And then if you have time this month, send us your completed tools or even just the draft tools, and we'd be happy to review them and give you any feedback. So that's your QI challenge for this month. Next month, we're going to talk about a different type of tool for quality improvement called driver diagrams. So I just wanted to get you all very excited for the upcoming month of quality improvement. And next slide, I'll end our quality improvement talk by just reminding you all that cohort-wide, we have a really important aim that we want to keep bringing you all back to. And that aim is to have 30% of our participating hospitals establish a multidisciplinary work group in order to oversee your work to address perinatal substance use. Many of our facilities already have these work groups in action. If you don't have a work group that has multidisciplinary inpatient, outpatient, obstetric, and behavioral healthcare support, we would be happy to talk you through the process. We have some tools and outreach letters that are available to you to help brainstorm. We're going to be asking you in the coming months to report to us, how is it going with your multidisciplinary work group? What's going well? What's not going so well? How is your work group overseeing the work that's happening at your sites? And I'm happy to open it up for questions for quality improvement. Otherwise, I'm going to pass it over to Elena to introduce Christine.
Thank you so much, Amber. So today, I just want to make sure she is visible. My screen got all wonky when I shared it. Christine, are you still there? I just want to be able to introduce you so people can see.
Yes, I'm still here.
Okay. So I wanted to introduce Dr. Christine Gold. Dr. Christine Gold serves on the Support Colorado work group, which has been working on updating the toxicology guidance for the state. Dr. Gold serves as a pediatric hospitalist, and we're super excited today to have her here to share with you this updated guidance from Support Colorado. So I'll pass it over to you, Christine, and I'm happy to share your slides, or if you want to share them, whichever works best for you.
Sure, if you don't mind sharing them, that would be great. Next slide. Awesome. Thanks again, everyone, for having me, and I'll try to go quickly enough that there's time for questions. I see that there's many people on this meeting who actually worked on this as well, or a couple of people, so please feel free to correct anything that I say. But we're going to talk today about some new guidelines that are coming out regarding indications for toxicology testing at Colorado birthing facilities. Next slide. So it sounds like people in this group are familiar with both Illuminate Colorado and Support Colorado. These guidelines are coming out from the Illuminate Colorado Policy Analysis Work Group, where we were tasked with trying to improve some sort of standardized guidance on toxicology testing, since there's so much variability across different institutions and across the state of Colorado. Next slide. And again, just some pictures of the two different groups that you'll hear us talk about. Next slide. So objectives today, I'd like to introduce kind of from a wide viewpoint, the new guidance coming out about toxicology testing. We'll briefly review types of toxicology testing available. We'll talk about trauma-informed techniques that we do mention in the guidelines, and then briefly touch upon safe breast or chest feeding before discussing CPS reporting. So next slide. First, we'll start with introducing the new guidance. Next slide. So here's a snapshot of what the beginning of the document looks like. And the purpose of the best practice guidance is what I have highlighted here. But we really put a lot of emphasis in this document on our guidance intending to minimize bias, discrimination, and variability in the way toxicology testing is applied at different birthing facilities, both to a birthing person and their infant. We really wanted to review limitations versus benefits of toxicology testing in the care for patients who are affected by substance use. And it's important to emphasize this guidance is not meant to be overly prescriptive or trump the judgment of providers, but the idea is to give a framework that different institutions can review and adopt as seen fit to their own institution. Next slide. So right up front, I just want to clarify, and I don't know if your group has already reviewed this, but we do use some different terms to mean different things. So when we do utilize the term screening, we're really talking about the process of gathering information from a patient about their substance use. We're not talking about the testing, which is the biological sample that we obtain to demonstrate the presence or absence of substances. most organizations, I think if not all organizations, still say that all pregnant and birthing people should be screened for substance use. And we continue to recommend that in this document, that universal screening of all pregnant and birthing people should occur. It should be equitable, should be applied to all birthing persons and infants, regardless of insurance status, background, etc. Not all patients are tested for substance use, though, and there aren't any major medical organizations that I'm aware of that support universal testing for substance use. But when we use the term screening here, we're not talking about the biological test. The test will mean the biological sample. We don't believe that a positive screen for substance use always necessitates a toxicology test, and that will be highlighted in the next slides. So next slide, please. Here's a quick overview. When it comes to toxicology testing, we did issue some guidance on indications for toxicology testing, which for those people present, I'm sure most people know, the indications in current birthing facility policies vary widely. When you think about testing indications as you hopefully review and update or adopt guidelines for your institution, we want people to think about how will the toxicology test result be helpful? Does it identify any additional exposures, or does it really actually contribute to changing the management of this dyad? But it's also important to think about how will this toxicology test introduce harm? And I don't think before going through this work group process that I really thought much about that as a daily provider. It can decrease trust between the medical team and the patient, and it does impact vulnerabilities that the birthing person has when these conversations occur. So the balance of how it's helpful versus how it's harmful is really important in deciding whether or not to obtain a test. Again, we still want to emphasize the trauma-informed care, and that conversations, we want them to be approached in a non-judgmental, supportive manner. And that way you will gain more information and create a better relationship. We do recommend that you consent the birthing person not only for their own toxicology testing, but for their newborn's toxicology test as well, which I think will be a change in recommendations from what some institutions do. We introduce ideas in this guidance about doing a multidisciplinary huddle, which I'll explain more later, but where a group of people interacting with this dyad can discuss whether or not the test is indicated, and also discuss the results of that test once it's available. And then briefly at the end, we mention a plan of safe care and resource identification for families affected by substance use. Next slide. So toxicology testing criteria for the birthing person. There is a lot of variability in criteria right now, not just within our state, but across the country. A lot of these criteria have not been demonstrated to be associated with a positive test, but they have been associated with identifying people of marginalized populations. And we really want to focus on behaviors and not selective criteria when it comes to determining toxicology test indications. So we suggest in the guidelines for toxicology testing criteria for a birthing person, obviously if they present with signs and symptoms of intoxication, withdrawal, or altered mental status, there is a very broad differential for a patient presenting that way. Substance use is one of many things on that differential, but toxicology testing may be indicated and or helpful in that situation. There are times where a birthing person themselves might actually want to pursue toxicology testing to demonstrate their own recovery, or if there's uncertainty about unintended exposure to certain substances, if they recommend for themselves that they'd like the testing, we would recommend doing it. If someone desires to chest or breastfeed and one of these conditions exists, we also recommend toxicology testing. So if there's a report of substance use or a positive test during the last trimester of pregnancy, that probably warrants further multidisciplinary discussion and consideration of toxicology testing. If a birthing person presents with a history of substance use disorder and they are in active treatment, we do strongly recommend actual communication with the treatment program to assess the level of engagement with recovery before making determinations about safety of breastfeeding. Next slide. Changes of note, I would think, from what I've seen across different hospitals I've worked at for the newborn, I think this is a very pared down list. And we think that if a newborn demonstrates signs of either intoxication or withdrawal, it makes sense in that case to say that toxicology testing would be helpful to determine medical management for that newborn. If a newborn's birthing parent meets the criteria we just reviewed and the result would alter medical management of that newborn, testing might be considered. And we left in this guideline that if a newborn presents with the physical stigmata of fetal alcohol spectrum disorders, you would consider testing as well. What you'll notice that is not on the list for either the birthing person or the newborn are some of the selective criteria like adequacy of prenatal care, prior incarceration, prior loss of custody of other children, things that really haven't been found to be associated with substance use, but are associated with disproportionately affecting our marginalized populations. So I realize this is a change, but we worked really hard to review the literature and think through what really are the indications for toxicology testing. Next slide, please. So I just have this excerpt from the guideline and I wanted to review it here, which it states that before ordering a toxicology test, the reason for obtaining the test, how it changes the management, and how it can impact both discharge and disposition, it should be identified both with your conversation with the patient and documented as well. And again, we emphasize a multidisciplinary discussion with the birthing person, provider team, nursing, social work, and the family, as well as the pediatric team prior to administration of testing, so that everyone's on the same page and that different perspectives are appreciated and weigh in on the decision before it's obtained. We do recommend that all people who are ordering toxicology tests are available or are aware of the tests that are available at the facility, the benefits versus problematic aspects of that testing, and the risks of false positives and false negatives. We don't recommend just saying, hey, you meet this criteria, kind of arbitrary, you get this test. We really want providers to think through how the results are going to guide management of the dyad. Next slide. So we move from actual testing indications to reviewing informed consent in the guidelines. And I think this is probably a review for most people who've ever done consent, but informed consent would include both in the discussion and in the documentation why the test is indicated. You know, what reason do we think a test would be helpful here? What is the type of test that will be done? Not only what are the potential benefits of that testing and seeing the result, but what are the risks of that testing? Parents, at least at the hospital I work at, can decline the testing, and we do discuss what are the risks and benefits of refusing the test, just like we discuss the risks and benefits of accepting the testing. If someone declines toxicology testing, we recommend that in very rare circumstances would you still pursue that testing. If the birthing person is deemed to lack capacity, if you think that there is a compelling medical need for the infant despite the parents' declination of consent, then you would still go ahead and do it. And sometimes here in this hospital, we find that custody is changed from the birthing person to the county, and then they request the testing. So those are probably the only times we would recommend actually doing the test despite not getting consent. Next slide, please. The multidisciplinary huddle that we talk about and that I've talked about in prior slides, we actually give in Appendix A in this long document a framework for what that huddle or timeout would look like, including who we think should be represented in a huddle, and what we know about the dyad and what we think the indications are for the testing. We want to make sure we emphasize again that testing and requesting testing is not without harm, but also not without effects on the dyad. And so we want to make sure that we use team decision-making and multiple perspectives at these key points that can have life-altering effects. All right, next slide. I realize that's hard to see, but we did actually create a clinical algorithm as well that will be included in some form, either in the document or as a separate handout. I know that at our hospital, we rely heavily now on algorithms and pathways. And so the idea was to demonstrate how you move from being concerned about or obtaining a positive screen for substance use, how you move through the different aspects of care for that dyad. And next slide. So that covers the new guidance in a nutshell about how we're recommending toxicology testing be performed at the birthing facilities. I wanted to move on now to identifying the types of toxicology testing available, if you don't mind. So next slide. When it comes to the birthing person, I think most commonly we're talking about urine testing, and there are standard immunoassays, and then there's also more specific urine test that you can do. So the benefit of doing a standard urine immunoassay is that it's quick. You can get results at our hospital within hours, but there are problems with urine immunoassays as well, including false positives and false negatives. When it comes to the way the labs do the test, there's a higher threshold that has to be reached before the test is reported out as positive. And so someone who's used within the last 1 to 3 days, depending on a lot of other factors, might test positive on immunoassay. But if they've used a little more distantly than 1 to 3 days before the test, it might be negative, and that could be a false negative. There's also a lot of literature on false positives in urine immunoassays for amphetamines, and lots of things that can cause it to look positive for amphetamines when there wasn't actually methamphetamine usage. So it's important to know what your institution utilizes in terms of testing. And if there's concern for false positive or false negative in a urine immunoassay that was deemed appropriate, we do recommend doing confirmatory urine testing, which does have a lower threshold with which it will report out a positive. So it can give you a little bit of a better idea of the recency of substance use. Immunoassays don't always include synthetic opioids. So I know more recently at my hospital, we are now adding fentanyl to the results in an immunoassay, but synthetics include things like fentanyl or methadone. They won't flag as positive in your standard immunoassay in most facilities, so it may be falsely negative either way. Next slide, thank you. So when it comes to infant testing, there's umbilical cord tissue, which I think is becoming more common for usage in birthing hospitals. There's meconium, urine, and hair. So I didn't comment on hair in the birthing person, and I'm not going to comment more on it here, except to say that it is an option, but I have not found it to be something that we find to be a helpful tool in most hospitals. Urine, again, similar to what I just described for the birthing person, has its limitations. You can obtain that on a baby and get results pretty quickly. Obtaining urine on a baby, for anyone who's done it, can be tricky because they don't pee with any sort of predictable frequency. Oftentimes we have cotton balls in some sort of plastic bag trying to soak up urine. And again, the infant's result of positive or negative is influenced by so many factors, including the way the birthing person metabolizes substance, how much, how often, how recently they've used that substance. Meconium is something that, for anyone who's collected, is a bit difficult because substances are not deposited uniformly in meconium. So when you use meconium, you have to collect multiple stool samples over usually multiple hours to days, and then stir the sample and send it. And it takes 5 to 7 days to come back. So it's not typically going to yield useful information during the birth hospitalization. And umbilical cord tissue, this is something that we switched to here where I work because we save a 6-inch sample of umbilical cord tissue from every patient who's born, and we store it in the refrigerator so that if at some point it becomes known to us that we should do testing based on one of the indications, we still have a sample that we can use. Umbilical cord tissue results probably represent about the second half of pregnancy worth of use. There are false negatives sometimes in this because there is a certain threshold that has to be reached to report out as positive. Collection of umbilical cord tissue can also affect results because if there's still blood present in the cord, that can reflect medications we gave the birthing person in labor, such as fentanyl. But if the cord is squeezed too hard as we get the blood out, it can break the wart and jelly layer where the drugs or substances are deposited. And so there are benefits and problems with all of these methods of testing. Really, none of this testing, again, I've said it once, but I want to emphasize, suggests the level of impairment based on the presence of that substance. It doesn't reflect when it was last used, how often it's used. It's really just yes or no, I have this substance present here. And so it's really important to consider false positives, false negatives in the context of the conversations you've had with the dyad. Next slide. So again, I jumped ahead, but these are the limitations that we just discussed. And next slide, please. We do recommend in the guidelines that when you have a high-risk situation and you're trying to interpret toxicology test results, there should be someone in the institution that can actually interpret the results or help in interpreting the results for the team. if you don't have someone at the institution you work at that is like a medical review officer, our poison control center actually will take any calls when there's concerns about how to interpret a toxicology test result, and the number is here and it's in our guideline. And so we really recommend people reach out and really think about the results they have in front of them if they've done a toxicology test before making decisions that affect the care of the dyad. Next slide, please. Okay, so moving on, we've just talked about different types of toxicology testing. We'll talk really briefly about trauma-informed techniques to utilize for care of substance-affected patients. Next slide. So we have a lot of this in the guideline. I'll go through it really quickly, but again, we talk about what trauma is for a patient and how that response to trauma is often involuntary or outside of a person's control. It's very common for past trauma to resurface in the perinatal period. So anyone who works at a birthing facility is likely to encounter patients who have experienced trauma. We do recommend that any member of a team who is caring for birthing individuals complete trauma-informed care, because it's really a universal approach, best practice when interacting with birthing persons. Next slide. Again, just to emphasize, trauma responsive care is strength-based and recognizing the significance that a patient can feel with power differentials, the past diminishing of their own voice, emphasizing safety in all aspects, and trying to create an opportunity for that patient to have a sense of control and empowerment. And we want to make sure that people are offering the choice to be actively involved in their decision-making that affects the care. Next slide. We do reference the 4 R's in trauma responsive care. And very briefly, we talk about realizing the widespread prevalence of trauma, taking universal precautions, recognizing signs and symptoms of trauma, both in patients and in staff and in their families, responding by integrating knowledge about trauma into the policies and practices that we have at our birthing facilities, and then resisting re-traumatization of patients, whether that's intentional or unconscious. Next slide. These are just some examples of trauma responsive care. And I believe that more and more people are talking about trauma responsive care, but if there's any questions about this later, I'm not an expert, but I'm happy to answer questions. Next slide. Okay, briefly, we'll talk about safe guidance for breast and chest feeding now. Next slide. There's a lot of different major medical organizations that do comment on ways to safely chest or breastfeed in the setting of substance use. Most of these, if not all of these organizations, recommend that if a birthing person is receiving maintenance therapy, such as methadone or buprenorphine, and they're in a treatment program, and you communicate with that treatment program and confirm their engagement, and there's no concern for additional substance use, that it would be safe to breastfeed in that circumstance. Aside from substance use, there are contraindications to breastfeeding in general, like HIV or HTLV presence, and patients who have a history of substance use may be at higher risk for those infections. And so it's important to make sure that medically they otherwise meet criteria before considering their substance use. Next slide. In general, the summary we would give for lactation consideration is that if a birthing person has been using a non-prescribed or illicit substance within the 30 days prior to delivery, we really want to engage this patient in a multidisciplinary team approach and determine the most appropriate safe feeding for the newborn. And we always want to discuss with that patient what are the potential risks to the infant versus the known benefits of chest or breastfeeding, and what is that birthing person's goal with the feeding, and try to work on a plan that is safest for them. There are a lot of questions and actually a lot of discussions happening about cannabis and lactation. Almost every medical organization recommends refraining from marijuana use or cannabis use while being pregnant and while chest or breastfeeding. No organization really seems to go as far as to say, if you use cannabis, you shouldn't breastfeed, but there's a lot of discussion, and hopefully the CDPHE will be issuing some new guidelines on this soon. So I'm happy to talk about that more later if it's helpful. Next slide. Okay, very quickly and lastly, just talking about changes to CPS reporting that may seem like a change in this guideline. Next slide. So for those who may not be aware, in 2020, there was a statute change in Colorado where when it came to defining the neglected or abused child, they actually struck out the language that referenced including that a child tested positive for a certain substance. And instead, they changed it to mean that the child is born affected by alcohol or substance use, and their health or welfare is threatened by that substance use. And so that hopefully explains why we are trying to de-emphasize the testing as the #1 driver of care for substance affected families, because the presence or absence of a substance on a test does not necessarily mean that there is a judgment that should be given about the person's ability to parent. And so we have to think carefully about this. So next slide, please. So when we say a child is born affected by substance use, it still remains somewhat vague, but it's defined as that substance use impacts the physical, developmental, and/or behavioral response of the child. And the health or welfare is threatened by the substance use when the medical, physical, or developmental needs of the newborn are unlikely to be met by the parents or caregiver. Just like there's benefits versus harms in asking for toxicology testing, there's also benefits versus harms in reporting to CPS. And if you have a multidisciplinary huddle again after a test results, those should be discussed and balanced when the decision is made whether or not to report to CPS. In terms of discharging patients, whether or not a CPS report is deemed appropriate, we still recommend that families affected by substance use, when discharging from the birth hospitalization, have a plan of safe care, which if anyone's interested, they can reference that in Appendix B, and also providing as many resources as we can for that family. And we did compile a list of resources in this document, which can be found in Appendix C. So please reference the document and take a look at what is there. And next slide. So I hope that wasn't too overwhelming, but in terms of document recommendations, we still recommend universal screening for substance use of all pregnant and birthing persons. But we don't think that toxicology testing is always indicated, and we want people to really think about the benefits versus risks of that testing before it's ordered. Testing really is only one piece of information or one tool in providing care for and developing a medical plan for these dyads. We do think that determination of safe feeding should consider history, consider test results if they're obtained, but also be individualized. Really want to emphasize again, CPS reports do not have to be automatic after either a positive screen or a positive test, but the entire clinical picture should be considered. And multidisciplinary huddles really would be what we'd recommend as best practice for making these decisions, so that an entire team who represents that dyad, including the birthing person themselves, can make best decisions for the care. Next slide. So this is my email. Please email me if any questions or concerns occur after this meeting. I'm really happy to answer them. And I have a list of references, I think, on the last slide, but that's everything I have to present. And please feel free to ask questions or comment.
So we have about 15 minutes, and we definitely wanted to leave room for questions for Dr. Gold, because I know this has been a hot topic for all of y'all. So feel free to either chat it in, come off mute, and we can have this be an open discussion about the toxicology guidance.
Just curious if about anybody using that multidisciplinary huddle model. I would just be interested in hearing a little bit more about that.
I can say for the institution that I work at that we've created a multidisciplinary huddle that just kind of rounds daily on all patients, but we are working to establish a better one related to substance affected families. And we had some changes in our social work position, and we finally got a really good team. And so that's actually one of our goals, but I don't have experience that I think I can comment on yet about that personally.
Thanks.
I will say one last thing though about it, which is that I think sometimes when we bring up the idea of a multidisciplinary huddle here, it's hard because we have providers who may be caring for a patient postpartum who are also covering triage or laboring patients, and everybody's busy, and it would be very hard to probably get an in-person meeting as frequently as may be warranted for our families affected by substance use. And we've been tossing around the idea of starting that multidisciplinary discussion just using a secure chat, because we use Epic here with the relevant players for the day who are represented on that team, and then trying to see what, if anything, has to happen in person versus what can be discussed that way, just to accommodate people's busyness on the unit.
Anyone have any other questions for Dr. Gold?
We'll ask another question. So, I think we've seen in these meetings some information on marijuana use and breastfeeding. And I'm just wondering if you can speak to that a little bit more. And or anyone else like has a sense of like the direction. I know we're looking for more information, but I think I just had an experience this week where it was like, you shouldn't breastfeed if you use any marijuana. And I'm not sure that messaging feels right to me. So just curious where we're headed.
Yeah, thank you for bringing that up. I think that is a really important topic, and we're talking about that right now. The CDPHE has drafted a document about guidance on cannabis use and breastfeeding, and there was just a meeting last week where medical providers were commenting on the document, and I think there will be some adjustments. In general, I think we want to message and provide education as the most important process when working with a birthing person who desires to chest or breastfeed and also has cannabis use. And I think in general, what we have been doing is saying we recommend you cut back or refrain entirely while you plan to chest or breastfeed. Here's what we do versus do not know. I think the studies we do have about the effects of cannabis use and breastfeeding are old, and they're also from a time where cannabis was much less potent, but they do suggest potentially some developmental concerns down the line when children reach school age. And so we want to be clear that while we can't say for sure, a lack of current evidence doesn't mean safety. And we want to acknowledge the benefits of chest or breastfeeding balanced against whatever risks may be there that we haven't fully delineated yet. I think what most organizations, like I said, emphasize is that the education should be emphasized that we recommend cutting back or refraining if someone has the goal to chest or breastfeed. We know realistically, it's actually very hard to cut back or stop entirely from cannabis use with the intention of breastfeeding, especially when someone is a heavy user. At our institution, we currently follow the Chosen Quick guidelines for feeding groups, which is the Colorado Hospital Substance Exposed Newborn Quality Collaborative. And we do here currently delineate between those birthing persons who admit to heavy cannabis use versus those who are lighter users to help delineate the safety of chest or breastfeeding. But I think my guess is that the messaging is going towards promote breastfeeding while educating and strongly suggesting to reduce or refrain from cannabis use. I know that I'm being purposely vague, but that seems to be the direction it's going. And I think that refraining or withholding lactation support from a birthing individual who has been appropriately educated and counseled is probably not what's going to be recommended.
Looks like we have a question in the chat from Gina. Gina asked, do you have any sample policies that can be shared in regards to testing? Our policy has more of the criteria you discussed about late care, et cetera.
Yeah, so we're piloting at my institution, changing our hospital guideline to reflect the guidelines I just discussed here. It's just not formally published yet, but I'm happy to share the draft if that would be helpful with anyone who's interested, please just shoot me an email and I can send that.
Yeah, that would be great.
I'm curious to know who the document is directed towards. Like, it's mainly directed towards care providers in the hospital setting, or is it, you know, what's the final document going? Who's that going to be distributed to? And, you know, obviously CPS has their own document they follow regarding substance use in this scenario.
Right. So it's intended to be utilized by all birthing facilities in Colorado. Again, not as like you just take it and you make it a policy and you strictly follow it, but as guidance for all birthing facilities and their own individual policies regarding toxicology testing. So I think it's not just geared at providers for one part of the dyad, and it's really geared toward the multidisciplinary team. So we'd like to distribute this to all facilities that care for birthing persons and involve multidisciplinary engagement, social work, lactation consultants, providers from obstetrics, midwifery, and pediatrics, et cetera, to be the audience to receive this.
Thank you. I'd also be curious to know how much of like the science you have in that document, or that you have available, what the statistics are as far as the you know, false positives and false negatives of urine testing. And, you know, because I think sometimes it's hard to get people to understand that the testing isn't the end all be all to whether or not you know, file a CPS report. And so is the science and the stats in the document, or is that kind of just the funneled down version of it?
Yes, there's a ton of references behind this. I don't know if they're included in the final like policy that we send out or not. I know Kelly's on the call and Callan's on the call too, if they want to comment. But I'm also really happy. I sent my email in the chat here. If anyone's interested, you can send me an email asking for that and I can get you information. We did work with both CPS and with a medical toxicologist while drafting this guideline. And our medical toxicologist is amazing and really open to providing resources or information on that topic. So I'm happy to connect you with that person if that'd be helpful.
Okay, thank you.
Dr. Gold, thanks so much. This was very informative. I've actually seen this guidance, but I think you explaining it and walking us through it, I think was very helpful for me. I think the part as a nurse and then now a nurse midwife that's so interesting to me is the harm reduction piece of it. I think harm reduction sometimes feels very uncomfortable to healthcare providers because, you know, the Hippocratic Oath is do no harm, and doing no harm is not always possible. And so for me, I'm super interested in how it is that organizations like CPCQC can help disseminate more information about harm reduction around perinatal substance use. And I also wanted to plug for us two other things kind of in relation to this is that the neonatal toxicologist who contributed to this, Dr. Lori Halmel, is presenting at our annual conference in May on some of these topics as well. And so if you guys want to dive a little deeper with more of the people who actually contributed to this document, I think it's going to be a really fascinating opportunity to go kind of to the next level with this. We also have another webinar coming up in 2 weeks for our cesarean reduction quality improvement project. But we've chosen a topic that bridges well with perinatal substance use, and that's opioid prescribing post-cesarean. And I think it's, you know, when we talk about multidisciplinary work teams, I think we sometimes often leave off anesthesia, and they play such an important role if we've identified substances, you know, pre-birth and during the birth experience, about integrating them in for adequate and safe pain control. So I'll put a plug in for that webinar that happens on April 27th as well.
Thank you. Yeah, I think harm reduction is really huge and we don't talk about it enough. And I think what I'm personally experiencing as I bring this to my institution and try to adopt the guidelines is that de-implementation is much harder than implementation. It's really a hard lesson learned, but asking people to do less safely is harder to get buy-in than if I came with data and said, here's why we should do more testing. So it's definitely something that as I learn about that, I'm happy to share with other people.
Thank you so much, Dr. Gold. And thank you so much for presenting today. Dr. Gold put her email in the chat So you're welcome to email her. I'll also be sharing this recording as well as the slides. So if you want to go back through and look at those references that she put on the last slide. And then when this guidance is published, we will be disseminating that all to your emails as well. So again, thank you so much, Dr. Gold. I'm going to launch our evaluation poll. So if you could just take a few moments and complete that. I've also put in the chat both the link to our webinar on April 27th, which we'll be talking about opioid prescribing practices post-cesarean. It should be really multidisciplinary presentation. And then I also want to put a plug in for our conference. I know that you've been getting emails about it, but our conference is coming up in the beginning of May 12th. It's going to be a really great day. We have a keynote speaker, just Nina Martin. You may have heard of her from the award-winning ProPublica series called Lost Mothers. So that's going to be a great presentation. And then we're also going to have another presentation about the toxicology guidance, including Dr. Helmo, some information about perinatal navigation, and hearing voices of recovery, some lived experience expert presentations. So it should be a really great day. I put the link to that in the chat for you to register. It will be in person, which is really exciting. It will be at the CU Anschutz campus. So that is coming up. And yeah, so if you could just complete the coaching call evaluation. And it was really great to see all you today. And I will be sending out the slides and the recording after this. And I hope you all have a really great rest of your day.